Good afternoon. I want to start out actually by just thanking the organizers of White for just having a consistently awesome conference and workshop for us. In fact, the two co-authors on this paper I met for the first time here at White, 5 years ago now, right? So it's been a great source for collaborations that have been long-term and really productive, at least for me. So the paper I'm presenting today is titled Health Information Exchange and Reduced Healthcare Spending. Clickers aren't working, okay. So the great thing about White is as the day goes on, you have to do less and less introduction, right? So you can just start getting right into what you're actually doing. But just very briefly in terms of health information exchanges, just to kind of set the platform a little bit here, the way we define them in this study is an HIE is really any organization or entity that's focused is to facilitate the exchange of health information between otherwise disconnected organizations, right? So that's kind of what we're thinking about here when we talk about health information exchange. Very briefly, right, we think that HIEs have the potential to lead to result in considerable benefits for the healthcare kind of sector, right, for healthcare just in general. Some estimates are in the range of $80 billion in savings once information exchange is nationally implemented. Some other studies have looked at regional value. So the value from HIEs come from two broad categories, and I'll stop here. So I know a lot of you guys know this. Right? When we think about quality gains from improved information sharing, so a physician has more information, they can make better decisions. And the other side of it is thinking about efficiency gains. Right? So if I have information about a test that's been done at another physician's office, now I don't have to do that test. And I can kind of create some efficiency gains in that space. With respect to HIE, though, there's a lot of open questions. It's one of the spaces, while we've looked at EMR considerably, and partially it's probably due to the availability of data, the empirical work kind of in HIE has been a little bit more limited, right? And some of these important questions kind of actually extend to health IT investments in general, right? But is the value that we estimate, is that actually realized in practice? If so, what is the magnitude of these savings, of these benefits? And in particular, the question we're kind of interested in is which stakeholders actually accrue these benefits? How are these benefits parsed between the different players within healthcare? We focus specifically on the value of HIEs to medical payers. So does HIE reduce healthcare spending, i.e. does the value accrue to payers, right? And we suggest that this relationship is particularly tenuous, right? So the relationship between health IT investments and the value that payers hope to accrue, we suggest that that's a little bit problematic and that payers have kind of demonstrated implicitly and also explicitly some skepticism given the current kind of environment in healthcare that they will actually reap these benefits, these promised benefits from health IT investments. That dialogue has also been kind of consistent within the context of health information exchange. Right? So in this paper, an earlier paper by a co-author of ours, in this paper, Julia Adler-Milstein and others, they find that payers are actually noticeably absent in terms of stakeholders in health information exchange initiatives. Right? So they stand to benefit considerably from the implementation of these exchanges, but when it comes to the stakeholders, they tend to be kind of noticeably absent. Okay? And we suggest that at least one reason this is the case, and this is also something we've talked about a lot already, so I won't belabor the point, is this idea of this misalignment of incentives between medical providers, hospital administrators and physicians, and their payers, right? So under the dominant kind of reimbursement schemes that we have currently, medical providers don't have a lot of incentive to reduce the intensity of care that they're providing, right? Every additional redundant test results in most of the time, right, or a good portion of the time in additional revenue for the provider, right? The empirical evidence in this space also has been a bit mixed, right, and has some important limitations. So there's been some evidence that HIEs reduce redundant tests. Some studies find a mixed effect, so some sites, some hospitals will have a reduction, some won't. In another study, they find that if they randomly actually provide additional information to providers, they find no effect. So there's been kind of, which is also a common theme within health IT literature more broadly, some mixed empirical evidence in this space. Another important limitation potentially is that a lot of this has been focused on a particular region, right? So a specific health information exchange, a particular region. Some of it has been cross-sectional, more correlational than causal. So we hope there's some space here in terms of the empirical literature for kind of extending or presenting some novel evidence in terms of the value of health information exchange. I'd also suggest that actually the evidence within the EMR literature or the EHR literature has been particularly mixed when it comes to the value proposition for payers, right? So the papers that at least I'm aware of, and I'm happy to learn about new papers, find either in some cases actually a positive effect on payer spending after EMR adoption, right? Or find just no effect in terms of reimbursements after EMR adoption by hospitals. So we look at this using panel data from 2003, 2010. So we have national data on operational exchanges using previous surveys done again by our co-author Julia Adam-Nustein and some collaborators. So they've done a number of surveys for health information exchange. We use that to create kind of this panel of operational HIEs over this time period. We also use average Medicare expenditures per beneficiary. We look at this at the hospital referral region level, and this is data coming from the Dartmouth Atlas of Health. And then we use a number of other data sources, right? So generating our controls from things like the area resource file, other data from the Dartmouth Atlas of Health, HIMSS, the CMS impact file, kind of the common data sources that we use a lot in our analysis. So kind of using the workhorse here of econometrics, right, the fixed effects linear model, OLS, our dependent variable is Medicare expenditures. Obviously our important independent variable is whether a particular hospital referral region had an operational exchange at that time period in our data. Okay. Again, our unit of analysis is the hospital referral region. Looking at our data, we find that most HIEs, in fact, 71 out of the 73 operational exchanges in our data set operated within one hospital referral region. Right. It was uncommon that they had partners or considerable operations outside of one hospital referral region. And then we have a set of controls, a range of controls. So we control for health IT adoption. We control for a number of healthcare market factors, thinking about healthcare capacity, number of hospitals, home health, nursing homes, inpatient days, outpatient visits, et cetera, et cetera. So some common controls kind of in our analysis. We also have some controls for kind of changes in healthcare quality. We use mortality rates. This is using Medicare data, also hospital discharge rates. Again, using Medicare data. This is from the Dartmouth Atlas of Health. And again, and then additionally, we have some demographics. So age, population, unemployment, et cetera. So, and then finally, of course, we have market fixed effects and time fixed effects. So as others have argued, we suggest that this kind of initial estimation gets us at least some of the way there in terms of identification. Maybe we have a little bit more to go as well. But using kind of this initial model, we actually find that operational HIEs reduced healthcare spending per beneficiary per year by $123, or about 1.4%. Okay. So I know some of my fellow empiricists are looking at me like, yeah, maybe, right? Not sure I believe you. So I'll try to spend a little bit more time maybe trying to show the robustness a little bit of this result. In fact, most of this was done to try to convince ourselves that we actually found this result, okay? And, wrong burgundy twice in one presentation. Come on. There we go. Okay, good. I'm glad that happened. I'm going to savor that moment for the rest of my life. So we started talking a little bit about incentives before. Okay, so we mentioned that there's this misaligned incentive issue within healthcare. So how is it under these conditions are we finding these effects of operational HIEs? So we try to evaluate this a little bit further, and we use as kind of a proxy for healthcare markets that have less of a misalignment of incentives, this measure of Medicare Advantage penetration. So Medicare Advantage is this plan that's available to Medicare beneficiaries where it's actually a capitation plan, right? So providers are given a fixed reimbursement per patient within a particular kind of diagnosis class or a particular patient group, okay? So we argue that in markets where there's higher levels of Medicare Advantage penetration, right, providers have more of an incentive, right, to lower costs in a way that's advantageous also to payers. Okay, so we do this analysis. So this is our original estimate. If we control for Medicare Advantage penetration, the estimate is robust to that. So remember, we have all these other controls in the model here as well. But if we look at the interaction between operational HIEs and Medicare Advantage penetration, we actually find this negative interaction. Okay, so what that's saying is that the regions that are benefiting from operational exchanges are those that have higher levels of Medicare Advantage penetration, i.e. we argue that those are regions where the misaligned incentive issue is less, right? Or there's less of a misalignment of incentives. There's also, of course, always the endogeneity question with any of these technology investments that we look at. That's certainly the case within health information exchange. There's a lot of selection in terms of which regions adopt health information exchange. If there is some time varying factor that's differentially correlated with regions that have health information exchanges, et cetera, right? The common kind of identification issues, right? Our estimates now, there's some concern about bias. I think there is also, it's worth stopping. I'm doing a little bit okay on time, but it's worth thinking about, and I'm not exactly sure on this to be honest, but whether we can think about an HIE becoming operational as kind of a quasi-random event over time, right? It's not really this very predictable event, right? So the choice to pursue an exchange, to start planning for an exchange, that's obviously a very predictable event in some sense. It's selection to be sure, right? But the moment in time when an HIE becomes operational, right, do we consider that as kind of more of an endogenous or more of an exogenous event, right? There's a lot of other factors that go into when and the instances that it becomes operational. They tend to be delayed a lot, right? So kind of thinking about whether there's time varying heterogeneity, whether that's a concern. But we look at this in our analysis. So we start by restricting our sample to only regions that actually have an HIE. And what we do is we kind of exploit a feature of our data in that we have data not only on operational exchanges, we also have data on whether a region has an exchange that's planning. So is there an HIE that's starting out, but they're not yet operational, right? So if we restrict our sample to that subset of healthcare markets, we still identify a significant effect of operational exchanges. Now the coefficient is a little bit smaller, right, but still a significant negative effect. If we just look at the regions that have an operational exchange, so this is effectively a before and after analysis. Before you have an exchange, how much are you spending per Medicare beneficiary? Afterwards, how much, right? We still see this negative significant effect. We look at as kind of a sanity check also whether planning exchanges lead to any reduction in Medicare spending, right? So if we have simply an exchange that's not yet operational, we shouldn't see any benefits from that exchange. In terms of, we find a small, highly insignificant effect of planning HIEs. We consider this kind of reverse causality concern using lead variables. I've been told by some really good methodologists and empirical folks that we could also do this a little bit better, but using these lead variables, which effectively looks to whether there's a pre-effect, right, whether there's a pre-trend of reduced spending for regions that adopt operational exchanges. We don't find evidence of that, and we find that this main effect is kind of robust, including these lead variables. And then we also use this price-adjusted measure. This is actually a pretty interesting measure that the Dartmouth Atlas of Health does, where they normalize spending by the variation in DRG weights between healthcare markets. And that basically says that, what you reimburse a physician to do a procedure in South Bend, Indiana, where life is really cheap, isn't the same as what you would reimburse somebody in Miami or New York, right? So they normalize the data for that variation in basically the cost of providing care between regions, and we find this, that our result is robust to that kind of adjustment. Okay. I won't spend too much time on the contribution. I'm running out of time, but I'll let you guys judge whether that's actually there or not. But generally, we think that this is maybe one of the first studies or an early study that's actually demonstrating some of the value add of this HIE value proposition, particularly to medical payers. Another thing that we really think could be important is this idea of empirically testing or starting to proxy for this misalignment of incentives issue. So if misalignment of incentives is, kind of theoretically we think it's a very important kind of issue within healthcare, can we start, thinking about that empirically and seeing whether we can find some evidence of that? More important, though, are the limitations of the study. So we'll only use Medicare data, Medicare spending, right? So we have to start thinking about whether some of this extrapolates to other kinds of payers. The good thing is Medicare is such a huge portion of what we spend on healthcare in this country. So even hopefully an event that's localized to that kind of a payer, maybe it's an important effect nonetheless. We don't really talk a lot about the net effect, right? So we're investing a lot in HIEs, but we're not talking about whether these gains are actually overwhelming or overcoming what we've actually invested. And I always have to leave the indigeneity concern. Unless it's a random event, you still have to worry about indigeneity. And also, if Jeff McCullough catches me after the talk, I'll just tell him it's in the slide. Indigeneity is still there as an invitation. So leave me alone. No, I'm kidding. So I'm actually out of time. I would actually love to hear any comments, after the talk, any ways we can extend empirically or theoretically the paper. And I'm sure our discussant, who hopefully isn't too mad at me because I sent him the paper really, really late, can also offer us some insights about how we can improve. Thank you.
He sent the paper yesterday night. And trust me, all the analysis is fresh from oven. So, and I prepared my slides today morning, so that's much more fresher. The paper is good. Establishing the value proposition of some of these national big things, such as HIEs, is a quite uploadable effort, particularly when those things have not been established in the literature. So they are exploring how HIEs can really result in systemic cost savings. Of course, the arguments come, reduction in duplicate tests, reduction in administrative or coordinate efforts. The study claims to investigate the impact of HI on total spendings, although they operationalize it only for medical expenditure. Strengths, pretty good matched data set. I don't know where from they have collected all this data, but they have done it well. This is very timely when there is a policy debate whether HIEs are really adding value or they are just another fad which is going to dissolve. And coming from Colorado, our HI is currently struggling to establish their value proposition on the verge of shutting down. DC HI had shut down already. I don't have much to say on the empirics part, which seems pretty robust. But what I was struggling in the paper is to find any theoretical framework to explain why should HI really impact the total overall cost saving. So a couple of things that came to my mind, which probably you can explore as you go ahead. So there has been enough talked about the clinical IT and admin IT information technology, differentiation of EMRs and so on and so forth. Probably take some of the thoughts from there and apply it to the HI context and see that is there any clinical oriented cost saving? Is there any administrative cost saving through transactions and coordination cost saving? So that's one suggestion. As far as you can flesh out that, it'll be a good perspective. The dependent variable caters to one segment, and they have admitted that obviously they need to find, I believe total spending for HRers are available. I think there's a paper by Cutler et al. Which have used that, so you can explore that. On the DV side, on the independent variable side, you have talked about only operational HIs as a binary variable. And I think Niam has a paper forthcoming in ISR, which he argues that HIs are more of a verb. So can we measure the intensity and degree of the HI? How much data they are really exploring? How much data they are really exchanging? So in other words, you might find a J-shape or a U-shape curve over there that after a particular point, the value proposition is not that high. Or after some point, the value proposition is high. So going that direction probably would make more believable results. They have some other smaller points. What happens when the HI closes is that if the HI closes, then the spending really becomes very high or very low. Multiple HIs, for example, in the state of Newark, how do they do, and how do your study talk about those factors? These are a couple of suggestions. Thank you.
Thank you. EPTs. Good afternoon, everyone. This is Mehmet Ayvacı from University of Texas at Dallas, Tyndall School of Management, Information Systems Group. My collaborators are Turgay Ayer and Jan Bulaci from Georgia Institute of Technology, Industrial Engineering. We are working together with the HCAP team from HRQ, Dr. Zeynal Karaca and Dr. Herb Wong. The previous talk has set the stage, given introduction. You guys already know about health information exchanges. HIEs, the electronic networking of health information, is sort of mirrors the enterprise EHR systems where the data is gathered from different entities, labs, pharmacies, hospitals. And what we are focusing in this work is the emergency departments and the use of HIEs in the emergency departments. And use of each HIE in emergency is a reality for me, especially at the last week because of the Ebola case that happened right next door, literally. It's only 1 mile away from my home, and I had to drive through, so I can talk in the meantime. So why it's coming up. The Ebola case, it happened in the Presbyterian Hospital, Dallas. It was interesting. Maybe this is a story to share with you guys. So what happened, one of the physicians has said that what the nurse was seeing on the EHR screen was not available what the physician was seeing in his own screen. And that's part of the reason why this health information sharing did not happen at the organization level, within the organization. So you can imagine the outcomes. The unfortunate man has died 2 days ago from Ebola, and you can imagine the impact of not having the intra-organization information sharing, and you can project that to not sharing the information between different organizations as being a serious problem as it is. We are working on a different problem in emergency departments and health information exchanges. We are working from an operational perspective. We use a large healthcare data to inform hospital administrators in terms of what to expect from adopting HIEs in the emergency department. And we find, in a nutshell, what we find is when HIE is implemented, patients are moving through the ED faster. But there is some variation across the years that we study. We also look into the effects of crowdedness and severity in this work. HIE perspective, there has been some hiccups. We all know about it in terms of HIE adoption. Although this is the case, ED is a relatively common HIE application setting, and there is the incentives. I mean, Idris has talked about the misalignment of incentives, but in the ED, you're competing with time, and with the expected payment reforms and everything coming along, the bundle payments and everything, it is expected that HIEs are going to be more common, and it is expected, it is quoted that it's on the right trajectory. From an ED perspective, you might heard at different times that crowdedness is a big issue in the emergency department. From an IOM report, Institute of Medicine report in 2006, crowdedness, they call it as crowdedness epidemic in the EDs. You see a stable emergency department, and you see the number of visits to the EDs are increasing. But the same report says HIT being the crucial for reforming EDs. And the information was not available and still holds. So how do they help? Again, Idris has referred to some of those, and they also find reducing costs. They made a very good case of reducing costs, avoiding redundant imaging, mostly through hospital admission reductions, avoiding readmissions, reducing medical errors, improving diagnoses. The studies that are quoted and many others try to look into this problem. And another aspect of it is the routine users of HIE believe that there's a substantial impact on how the patient is flowing and what the clinical workflow is. From different studies, they say that, they quote, information moved patients faster. Another one, HIE definitely improves efficiency and patient care. You might ask about, from an operational efficiency perspective, you might ask, if you are trying to see how it affects, what should we measure? Thinking about what happens with the HIE. Things that could happen are you can reduce the number of tests that you do because you have access to information, it's available, and you don't do it. Or you have better information, and because that you have access to better information, you might end up doing more. And you are introducing some sort of a variability into the whole process, which might increase the length of stay, or the variability is going to increase. It was also mentioned that there's high variability in terms of HIE use. So for that, we need to explore factors underlying successful HIE implementations, maybe from an operational perspective. And the studies to the date, not weak research design in the sense that they didn't do it, but most of these studies are predating functional HIE use, or they are small in sample or institution-wide. Only one institution is studied. What we are doing here is we are exploiting a natural experiment. To do that, we are using data from a large institution to the best of our knowledge. Among the published papers that we were able to find, this is the first large-scale study that quantifies the HIE length of stay relationship at a state level. And anybody who's thinking about adopting HIEs, what is the benefit that they can get, they can use this study to find out what to expect. And also, one of our findings shows from the lag effect of the IT with the HIE adoption, there's a gradual improvement that you should expect. But however, this is a very early stage of our analysis. Similar to the previous study, I shared my slides with the discussant yesterday, the day before, and these are just fresh from the oven. The results are. These are the research questions. We are asking the length of stay and HIE relationship. We are looking into effects of when you have severe patient, does it lead to reductions again? We are looking at crowded versus non-crowded settings and how HIE is helping or hurting, or HIE not helping at all. We have initially attempted looking at the first three questions, and we are also planning to look at the advanced IT, when hospitals are implementing advanced IT, how the HIE's benefit is going to change. The data is coming from HCUP. This is a private database that is literally on the HCUP site. We don't get to touch on it. All the treat and release emergency visits in the state of Massachusetts between 2009 and 2011, which is corresponding to about 2.5 million patient visits per year. We have a minute-level length of stay. We have other granular measures such as the hourly volume in the ED across the year per month at an aggregated level. We use HIMSS data, and once we match, there were about 55 emergency departments matching to the HCUP data. We primarily use HIE variables from the HIMSS data, and we are using American Hospital Association data for hospital characteristics as well. No math, but just two types of analysis, initial analysis that we have run on this data. The top portion is referring to HIE only. So the hospitals which are implementing HIE, and we are doing pre and post sort of an analysis. In the second analysis, we are doing control plus treatment. In other words, HIE versus non-HIE. We have all the hospitals that adopted HIE and all the hospitals that did not adopt HIE in our data set, and run the analysis. Dependent variable is the log of length of stay. The variables of interest are HIE, the year variable, crowdedness, and severity. And we define crowdedness as being in the fourth quartile, above 75th percentile. Severity is we are defining for Charlson Comorbidity Index having 2 or more, 2 or above. And also the third variable that's appearing from top is the variable, dummy variable for HIE being applied in a certain year or not. And these are the controls that you see at the bottom. So quickly, I'm not going to go through these details, but this is the HIE implementers only analysis, and this is the number of data points. And in this data, there are only about 200,000. In the 2000, there's a little bit of less. And the middle table is referring to the hospitals who implemented HIE in 2010 and 2011, and you're looking at the means kind of going up, and in 2011 going down, and we'll see the results. This is the initial, and you can look at the dummy variable for year 2010, which is positive. For those for the pre-post analysis, there's 8.7% positive, and in the year 2011, there's negative. Crowdedness has increased the length of stay, but HIE has dampened the effect. In terms of summary, overall, with the year also included, 6% increase in the length of stay, and for 2010 and for 2011, it was a negative 8.9, which is interesting. The dampen effect is about 4% in the crowded setting, where you have increased to 10%. And severity is reducing by 3%, which is also interesting. But because it's difficult to assess HIE interaction due to small kind of a percentage. This is the data for HIE versus non-HIE. It's kind of a natural setting where we use difference in differences sort of an approach. And these are the numbers. You see that the 2009, 27%, 31%, and then in 2011, about 40%, which is almost 50% more as compared to 2010. And these are the means. And again, we see some increase, and it's hard to decipher, what kind of a trend we're going to get. But the interaction variable, what we get at the end is the interaction variable. In the third row that we see a smaller kind of a negative effect. It reduced the length of stay in the year 2010, and there was about 6.8% reduction in the year 2011. And we see similar sort of an effect, an increase in a crowded setting, but the interaction variable was so small. What we find, negative effects in year 2010 and 2011 due to HIE. When crowded, 6.6% increase with insignificant effect due to HIE. For the severity, it might help, but difficult to make a strong conclusion. In conclusion, we find that HIE is associated with reductions in the emergency departments, and it's we would like to study underlying factors. We have looked on some of them. The patient flow is definitely, it's quoted in many times. Patient flow might be changing with the HIE, and what are the mechanisms, investigating into what are the mechanisms that this is leading to a reduction of tests or diagnosis, your better or faster treatment or diagnosis, or elimination of testing or diagnostics. What are the underlying reasons? The year effects in the pre-post analysis worth investigating. It has been mentioned about the incentives. And it was specifically in the year 2010. Maybe one question is, I'm not making a conclusion, one question is maybe those adopters in the 2010 were the ones who want to jump ahead and, let's see and let's try it. And they maybe they were not the adopters that they were continuously improving their processes. Something to investigate, whether the incentives had cost them. Also, the role of overall implementation, whether this is a lag effect, IT lag effect. And we are using a large healthcare database from a whole state to make a good conclusion on whether HIEs help in terms of length of stay or not. As I said, this is the first set of analysis that we have obtained. We are going to be doing some sensitivity analysis on crowdedness, defining in different ways, severity. We're going to basically, using the Dranova's approach, we would like to try how advanced IT plays a role. Asking the question of why do we see what we see, and what are the mechanisms for reduction in length of stay due to HIE implementation, looking at the repeated kind of a setting to see whether it's because of the repeated tests, you're eliminating some of them, is some of the directions that we would like to go. And I think that's it.
Thank Mehmet for a wonderful presentation and very creative topic, and really use the HCAP data on the Massachusetts SEDD. So since I have only 5 minutes, I will just summarize some interesting thoughts and points that Mehmet and his co-authors come up with. So I want to remind one more time the key variables in the comparison between using the difference in difference comparison between hospitals with and without HIE adoption in these 3 years. They use the outcome as an aggregate metrics, the duration between admission and discharge for each patient visit in hospital. And the treatment is also dichotomous variables given 1 year, whether or not the hospital had health information exchange in the ER in 2009, 2010, and 2011. The coordinates, they used hourly dummy variable indicating whether the patient came in the hour that they had above or below the third quarter of annual census in that hospital. The severity is a dummy variable indicating 2 or higher Charlson comorbidity index. So just some basic sense. For example, of diabetic patients, if diabetic patients without end-stage renal diseases, they are coded 1. If they have end-stage renal diseases, they are coded 2. The highest Charlson comorbidity index is 6, and they are like HIV patients. And also, the authors also use difference in difference model that I pointed here. One point I want to make is they use hierarchical model with a lot of different levels of variables in the model, but the emphasizing in the patient visit as a unit of analysis. There are a lot of interesting topics using this data, and I would first begin with how patients flow in emergency department. And this, I would talk about them in detail in the following slides. So first of all, in the ER, either patients come in from ambulance or walk-in. They started with registration, and then they waited for the assessment, and after the assessment, they would be going to a triage based on their urgency. It's not about severity, but maybe positive associated. And then after triage, they got examined. So after exam, they got treated based on the examination. So after treatment, they will either go to other inpatient settings or in the same hospital to the inpatient admission, or they just A&E, they just discharged. So where is the health information exchange comes in this flow? This is worth to think about for using this data or in the future evaluating length of stay in the emergency department setting. Another curiosity I have is, authors use severity. Actually, it's not severity, it's a comorbidity index. It's possible patients with different clinical conditions would have very different length of stay, even they are low risk. I just point out 2 kinds of clinical conditions that they make a very big differences. One is the obstetric patients, and the other one is chest pain patients. High-risk patients did have very significantly higher length of stay, but low-risk obstetric patients would have higher length of stay than high-risk chest pain patients. The third point I want to make is the repeated outcomes in a patient visit. So each visit is nested in each patient, and then patients also clustered in the same hospitals. Authors may think about using generalized estimation equations to address the clustering covariate phenomenon. So I have some other points I want to make. So in addition to the average treatment effects on the treated, maybe we can think about using ARG, emergency severity index, as well as some the equation that I pointed out. This is the last slide that I would share with you guys using this very unique data. Thank you.
Thank you to the organizers, because it's been a fun one to be here for. I am a health services researcher at Kaiser in Northern California. And I want to share with you some findings from a study that we've been doing looking at EHR implementation within our Kaiser system. In this case, we're going to look at how implementing an inpatient EHR looks to be affecting outpatient care through health information exchange. First up, I'd like to acknowledge my study team and our funder, the NIH NIDDK. So I think you're absolutely right. Each paper introduces the next, I think, here. So just to hit on the points that have already been raised, we go into this with the idea that obviously HIE can facilitate patient transitions between settings, primarily by making information more available, which we think will probably improve care coordination and hopefully increase efficiency. Also touching on a point that was raised this morning, the evidence is fairly mixed, both about EHR and about HIE use. I would say, though, at least in our setting, we've previously published on associations between EHR use and improved patient outcomes in patients with diabetes, and many of you also probably found positive findings. So I'd say sort of we're set ourselves up to take a look then at how HIE appeared to affect transitions. And I would say there's still fairly limited evidence on hospital discharge, outpatient follow-up care, and how HIE might impact it. So basically we go about this to look at how implementing an inpatient EHR, which in our setting basically became a seamless HIE with the outpatient EHR, changed follow-up care in the 7 days after discharge. This is outpatient follow-up care. We looked at in-person office visits, at secure patient-provider messages sent through the portal, and in our setting at least those are free out-of-pocket to the patient. Phone visits, which are the way we sort of operationally count phone contact between patients and providers, and outpatient lab tests. And then as an admittedly sort of crude measure of negative patient outcomes, we look at, well, can we tell if patients needed to go back to the ED more often or were readmitted to the hospital at 30 days to see if we can pick up any negative effects. So the way we do this is through what we sort of lucked into as a staggered implementation of the EHR. So this was in a randomized design. It had nothing to do with research, but as far as we can tell, operational decision makers decided to roll implementation teams from one medical center to another within this 17-hospital system. It didn't look like, we double-checked that the implementation schedule was determined far before our study period, and it didn't look like it had anything to do with sort of clinical care outcomes. We double-checked that it had nothing to do with the diabetes outcomes that in the population that we looked at. And when they rolled out the hospital EHR, it fully replaced all paper charting in the hospital. It included all order entry and lots of decision support. And then it exchanged patient history basically automatically with the outpatient EHR, including order entry for outpatient follow-up and medication reconciliation became possible. So here's just sort of a schematic of what I just described. Basically, it's a timeline across the top, and then each row is a medical center, and you can see that as they go through time, each one comes online with the outpatient EHR, which is our sort of comparison group is the gray period where there is an outpatient EHR, but there is no inpatient EHR yet. So there's very limited health IT tools to look things up about the hospitalization, but it's not a seamless HIE at all. And then when each medical center turns green, they now have both an outpatient EHR and an inpatient EHR, and they're seamlessly integrated with full health information exchange. So what we do is look at patients with diabetes. This is a study among patients with diabetes. I don't think of them as being the only place you'd expect to see benefits, but it probably is a good case study of patients with chronic disease or with some sort of baseline level of clinical need to look at some of these outcomes. So we took everybody with diabetes in the clinical registry who was hospitalized, and between 2005 and 2011, which sort of bookend our implementation period, and that came to about 240,000 hospitalizations. And then, like I mentioned before, we look at each of the outpatient follow-up types of care, visits, phone visits, secure messages, lab tests, and then we actually grouped the follow-up in a binary way to say, did the follow-up include an in-person visit or did it not? was the follow-up accomplished basically through a combination of phone, secure messages, and lab tests without an in-person visit to see if there was a difference in that. And then again, we looked at the ED visits and the readmissions, and our primary predictor is inpatient, outpatient health information exchange via the inpatient electronic health record implementation. So we adjust for patient characteristics, including age, gender, neighborhood, SES. Importantly, patient copayment for the outpatient visits, because that might present a barrier as well, their risk score. We adjust for time trends, because there's a very long sort of study period here using calendar month for seasonality and a continuous year term. Medical centers separately, and then an interaction with the time trend for each medical center, and then we adjust for clustering by patient. I'll mention sort of, before I show you the results, I don't know if that makes sense, that we did a number of sensitivity analyses to make sure that this was sort of stable, regardless of ways that we could think to look at it, although I'm very open to suggestions here also. And so we compared findings by the way we define outpatient EHR status, and that was fairly consistent. I'll show you the results for all hospitalizations, but we looked also among non-elective hospitalizations, and those were also consistent. And then we varied the number of days post-discharge that we looked at these things to make sure what we find isn't an artifact of the cutoff that we chose. So this is what the patients look like. Again, it's about 240,000 hospitalizations. More than half are 65 and older, roughly balanced on gender. A quarter live in a low SES neighborhood, and nearly half are not white. And here's what we find. So again here, the rows are each of the types of follow-up care. The first chunk is the 7 days after discharge, the outpatient care, and then the last two rows are those events 30 days after discharge. What we did was use the model results to predict adjusted rates of follow-up encounters, both before inpatient EHR with HIE and after. And what you can see there, the significant findings should be bolded, are that any follow-up care declines significantly within 7 days, from 72% receiving some kind of follow-up care that we can measure before the inpatient, outpatient HIE to 69% after. Similarly, a decline in the number of patients that received an in-person office visit, and a significant decline in the number of patients with an outpatient lab test. No significant change in the number of patients that received a phone visit or who exchanged a secure message with their provider through the portal, and no significant difference in the proportion of patients who came into the ED or were readmitted within 30 days. And then using that categorization I mentioned before, the one where we sort of grouped, did their follow-up care include an in-person visit, or did they manage to get their follow-up care without stepping in person into a doctor's office visit? And we see that significantly increase after the inpatient EHR is implemented, and thereby there's inpatient, outpatient HIE. So it went from 23% of patients being managed without an in-person visit to 27% managed without an in-person visit through some combo of phone visits, secure messages, lab tests. Like all studies, we have some limitations, clearly. I think one of the biggest ones, and probably most obvious, is that we did this study in Kaiser, which is a specific integrated delivery system with a very sort of set way of delivering care. It also has sort of a payment model that's different from other settings. I would argue, though, that probably many other healthcare settings are sort of moving in a more integrated direction, so maybe it can be more generalizable in that way. Like I mentioned before, we didn't experimentally allocate the EHR or the HIE. We got it operationally, but as far as we can tell, we don't find it associated with things that worry us. And then I did mention earlier that we started out, so this isn't a study probably of 100% papers, 0% electronic data to 100% electronic data, zero paper. I mean, we certainly started with some patchwork of health IT tools that helped transmit some information between the inpatient and outpatient setting, but it really was fairly limited. So I tend to think of this as sort of a conservative estimate of what you would or could happen if you went completely from sort of 0 to 100 electronic data. And then one of the things, these are relatively fresh data also, one of the things that we've sort of struggled with as a team are that follow-up care, the way that we're looking at it globally, probably captures a whole mess of different and probably appropriately different complex care pathways for patients with different conditions and different needs and things like that. And so we've looked at these sort of global patterns, but of course, for every given patient, there's probably a unique set of appropriate care pathways. But overall, here's what we find. We find that using an inpatient electronic health record, which exchanged information seamlessly with an outpatient electronic health record, after patients were discharged from the hospital, was associated with shifts in the type of care patients received, including lower likelihood of office visits, lower likelihood of outpatient lab tests, and the one that I think is most fun, sort of increased likelihood of care being delivered outside of a traditional office visit, ideally due to this sort of availability of electronic information exchange. And importantly, we didn't see any statistically significant change in ED visits or rehospitalizations for these patients. So we don't at least have initial signs to be worried that they're getting less care and getting sicker and coming back in a more severe state later on. Overall, we think that this means that timely availability of complete clinical information using an integrated electronic health record between the inpatient and outpatient setting, which seamlessly sort of creates an HIE, is probably affecting efficiency of follow-up care services after hospital discharge, and is probably increasing the ability to deliver care through these non-in-person encounters. Thank you.
Great. Well, I'm Gilbert Gim from George Mason University, and thank you for the opportunity to be a discussant for today's paper by Mary Reed on the impact of an integrated inpatient-outpatient EHR on follow-up care after hospital discharge. I enjoyed reading this paper for many reasons, but one was it was only 5 pages long, and the second, I did receive it a week ago, so I had time to look at it carefully. Just a quick summary of the paper that Mary presented. It examines if the implementation of an integrated inpatient and outpatient EHR altered the likelihood of follow-up care 7 days after discharge, or ED visits and readmissions 30 days after the discharge. And what was interesting was the staggered implementation over this period of time that allowed Mary to take a look at both the before and after differences for the 17 medical centers. The other nice thing, it builds on prior work that looked at the implementation of an outpatient electronic health record. Mary and her colleagues had a publication in JAMA in 2013 that looked at what happened in Kaiser Permanente in Northern California when an outpatient system was implemented. And there, in that study, they found associations with a modest reduction in ER visits and hospitalizations for patients with diabetes. But they didn't find any significant associations between EHR use and office visit rates. What was really nice about this paper, it's a very rich data set that comes from Kaiser Permanente of Northern California. I saw an earlier version, which I thought was 315,000 patients with diabetes. It's about 250,000 in the sample. And the two groups included those in the before, about 91,000, and then those in the after, 150,000. And in terms of methods, Mary used logistic regression analysis with, I think, the diabetic patient as the unit of observation. I was a little confused because the tables referred to number of hospitalizations. I think it was the patient, though, that represents the unit of observation, but we can discuss that. The outcomes are here that's mentioned. The list of control variables was very nice. It included patient age, gender, race, ethnicity, neighborhood SES, medical center risk score, and a time trend, and others as well. That was quite nice. And the standard errors were clustered at the patient level. Just some of the key findings, as Mary already presented, it reduced the likelihood of traditional follow-up after 7 days. The first and third of these were significant. The odds ratio of 0.8 for the in-person office visit, and then the lab test odds ratio of 0.94. It increased the likelihood of what I call email communication, but it's that secure portal that was mentioned. That actually showed an increase. But unlike Mary's earlier paper in JAMA, there were no significant effects on ED visits or rehospitalizations 30 days after. So just briefly, just some comments and suggestions. Again, I don't know if you're planning to prepare another paper for JAMA or potentially a health policy journal. One of the suggestions was whether there was a potentially a comparison group of non-implementing medical centers. The findings could be strengthened if you had Kaiser settings that didn't implement the new system, or there was a partial implementation. But as you explained, it looked like it was implemented in all of the Kaiser settings, so that type of analysis may not necessarily be possible. But if there's some variation in terms of how the integration occurred from the first outpatient implementation, that may be interesting. The second big suggestion, and what I was looking for, was a kind of hypothesis that didn't seem to be in the paper for why we would see this change in follow-up visits after 7 days. And in particular, I was wondering if there was maybe a mechanism for improved care coordination. So specifically, and I'm sure the clinicians probably ask you this, how does the new EHR system alert primary care physicians or endocrinologists or care managers in a different way? Kaiser is a unique integrated delivery system, and they have certain processes already. But to the extent that this new system alters the workflow or facilitates the sharing of information, even if it's an anecdote or two, I think that would help to strengthen the paper. And then lastly, one suggestion, if you maybe wanted to go for a health policy journal or maybe HSR, is to focus on a subgroup of patients with multiple chronic conditions. You may in fact find different results with respect to the ED visits and or rehospitalizations. So for example, all of your patients include diabetics, but a patient with diabetes, there's a huge variation in terms of the ability to manage your HbA1c levels. So if you have patients with diabetes and a condition like congestive heart failure, where there is a high frequency of hospitalizations or frequent flyers, you may find some interesting results here with the subgroup. Guy David published a paper in HSR in 2014 that found reduced ED visits when he looked at patients with chronic conditions in a patient-centered medical home program, even though there were no effects globally for the population as a whole. So there's some interesting subgroup analyses that I think could really strengthen the paper if you wanted to go to a different journal. And then with regard to, generalizability, of course it's unique to the Kaiser system, as you mentioned, but I still think there's a lot of value in this paper. So thank you.
Hi, everybody. My name is Silal Atasoy. I'm an assistant professor at Temple University. I have started working on health IT related topics for the last couple of years, so this is my first wide conference. I've learned a lot so far, and this is a great opportunity for me to present in front of the health experts, so looking forward to your feedback for the paper. So today I'm going to talk about spillover effects of health IT investments on regional healthcare costs. This is a joint project with my co-authors, Pei-Yu Chen in Arizona State University and Kartik Ganju at Temple University. And like the other presenters, I have few slides that have already mentioned several times today, so I'll go through them really quickly. But we all know that rising healthcare costs have been an important public policy concern in U.S. for a long time, and they constitute a large portion of the GDP, and this trend is expected to continue in the future. And U.S. healthcare system is also known to be characterized by substantial healthcare waste, such as preventable medical errors, over-testing, unnecessary ER visits, and unnecessary readmissions. And of course, policymakers have been trying to find solutions to these problems, and one example of that is the HITECH Act. So this policy devotes around $19 billion for subsidizing EMR adoption, as well as imposing penalties on the institutions that do not comply. And the underlying belief behind these policies is that EMR improves healthcare quality and reduces healthcare costs. And this was mentioned by President Obama in his inauguration speech in 2009 as well. So the expectation from EMR is to improve communication, improve diagnosis, quality of care, and in turn, eventually lower the cost with reducing medical errors, unnecessary tests, and readmissions and ER visits. And despite these promises, the views on the impact of EMR adoption on healthcare costs especially have been inconclusive. Again, several papers have talked about these today. So we see a lot of positive outcomes in terms of healthcare quality and patient outcomes, such as lower mortality rates, better diagnostics, fewer errors. But on the healthcare cost front, it is more different results with both negative and positive correlations. So in a way, it is not very clear whether and how these improvements achieved in healthcare quality translate into reduction in healthcare costs, which leads to an overall skepticism about the EMR as a tool for cost reduction. Because on the one hand, implementation is costly and very demanding from the hospital's point of view, requiring a lot of changes in the processes and organization. On the other hand, the expected cost benefits are not existing clearly in the data. All these findings might say that hospitals may not be internalizing the benefits they achieve from the higher quality with all these technologies, leading to further insufficient incentive to invest in health IT. So the main question we're asking in this paper, can the benefits of EMR go beyond the adopting hospital? So a lot of the studies focus on the relationship between EMR adoption and the cost of the adopting hospital. But also, hospitals can be considered as a network, basically because they share a lot of patients. Hospitals that are located together, that are co-located, have the same pool of potential patients. And there are some studies indicating that there are studies who analyze the hospitals as a network, tell us that the patient sharing can be as high as 87% on a regular basis for hospitals that are in the same county. So this patient sharing we can expect to be even higher for local healthcare markets such as health service areas or hospital referral regions. So this patient sharing can happen directly, meaning from direct referral from one hospital to the other, or it can happen indirectly, patients just choosing to go different hospitals. And the same studies also indicate a lot of the patient sharing actually happens indirectly. Almost 94% of the patient sharing happens by patient's choice. This inter-hospital patient sharing is known to affect a lot of hospital-level outcomes, such as spread of infectious diseases between the co-located hospitals and the success of the patient education and prevention programs. Also, the regional level analysis is very common in health economics literature, and it's well proven that the healthcare resources and practices are highly localized in U.S. From policymakers' perspective, costs and spending are usually evaluated and planned as a regional phenomenon. So this can add up as another motivation to look at this question. So how does this apply to the context of EMRs? So we argue that EMRs can create regional spillover effects, basically from EMR adoption one hospital to the cost of another hospital, with two mechanisms that we could think of. So the first one is improved patient health at the time of admittance to the second hospital. And the second one is information sharing that also has been discussed a lot in this session. So let's think about a patient that gets diagnosed and treated in hospital A for a period of time. Then this patient moves to hospital B, either directly with a referral or indirectly by her own choice. And hospital A is equipped with advanced EMRs that facilitated a very accurate diagnosis and very high quality care for this patient. So when this patient moves to hospital B, she's already in a better health condition because of the better care she received, the high quality care she received in the first hospital. She has accurate diagnosis. So these things can help the second hospital to provide further care for her at a lower cost. So that's the first mechanism. And the second mechanism is the sharing of information. So if hospitals can share, if they're part of the same exchange system, or sometimes some information can be transferred by the patients themselves as well. You can bring your test results or share other source of information from your history. This can reduce testing, imaging, and procedures at the second hospital, so they don't go through the same type of tests again. And these two mechanisms are supported in more specific context of emergency rooms. For example, lower mortality rates are achieved and lower hospital costs are achieved with a very specific technology that links the caller ID from the phone to a local database that enables ambulance to get to the patient faster. So the patient is already in better health condition by the time ambulance gets there, and that reduces the hospitals to achieve lower costs. And also other presenters here mentioned all sorts of studies that indicating information exchange can reduce redundant imaging and testing. So overall, we're going to ask two major questions. Our most important research question is whether EMR adoption of one hospital creates spillover effects onto the cost of other hospitals in the region, and if so, what's the degree of this spillover effect? And if such spillover exists, what can be the factors that can affect the strength of the spillover? Here we're going to look at two different factors. One of them is the technology type. We'll differentiate the basic EMRs and advanced EMRs. And the second one is regional characteristics, and we're specifically interested in the distribution of equality of EMR in the region. So in other words, the question is, for achieving an optimal regional outcome, do all hospitals have to have the same level of EMRs, or is it okay for just some hospitals focusing on more advanced EMRs and some hospitals maybe lacking those EMRs, and patients can go to that hospital when it's needed from a regional point of view? So for our databases, we use HIMSS data for EMR adoption. We use Medicare for several hospital characteristics such as cost, number of bed admittance, employees, so on and so forth. I'm going to talk a little bit more about it at the empirical specification, but we're going to consider the hospitals that are in the same health service area as part of the same network. And we use the American Community Survey to get regional level characteristics for the HSAs: education, age composition, race, population, income. So this leads to a panel of hospitals between 1998 to 2010, over 30,000 hospital year observations. And from the HIMSS data, we're going to focus on the 5 EMR systems that already have been discussed today. And we can see that from the span of 1998 to 2010, there's a huge expansion in adoption of these 5 systems. And later on, we're going to further differentiate the basic EMRs and advanced EMRs following the HIMSS and other studies. So the first 3 systems are going to be basic. The last 2 are going to be advanced. And we can even see empirically that last 2, CPOE and physician documentation, they're less widely used. They're more advanced technologies. For the empirical specification, we're going to have 2 major equations for the main results. So the first equation is going to look at the EMR adoption of a hospital, of a focal hospital, and its effects to its own costs. And the second level, we're going to look at the spillover effects. Again, EMR adoption of a hospital, how does it affect the neighboring hospitals in the same health service area? So here we are focusing on the health service areas because they are national legislated areas that are focused on, that are designed for healthcare planning purposes. They're a collection of zip codes where residents get the most hospitalizations from. And we test the results by also using hospital referral regions and counties as other networks, and they look pretty similar. So for the first equation, the hospital level effects, the dependent variable is going to be the log of operating costs per admittance for hospital I at time t. So there's a panel of hospitals. And on the right-hand side, the main focus is the EMR adoption at the current time t, and also we're going to include the lagged effects, as a lot of presenters also have argued. A lot of these impacts takes time to occur. So we're going to start with the first lag and keep including further lags. And for the spillover effects, the main difference is on the left-hand side. We're going to have the average cost of all other hospitals in the health service area but the focal hospital. So we exclude the focal hospital that has EMRs, and we're going to analyze how that EMR adoption affects the surrounding hospitals. Controlling for hospital-level characteristics, HSA-level characteristics. Also, we include hospital-level fixed effects to absorb for permanent heterogeneity across different hospitals, and time-fixed effects to control for time-specific shocks that are nationally happening to all the hospitals, and standard errors will be clustered by hospital and time. So when we look at the first equation results, the effects on hospitals' own cost, we see the EMR adoption is positively associated with hospitals' cost per admittance at the current time period. And for the lagged effects, we don't find any significant results, and also the magnitudes are relatively smaller. So this indicates that at the time of implementation, it's costly, and that could increase hospitals' costs at the current time period, but that doesn't carry on to the future periods. So when we look at the spillover on other hospitals' costs in the same health service area, we see that on the current time period, there are no effects, even though there's a negative correlation, but small. And starting from T-1 first lagged effect, we start seeing negative significant impacts. And these impacts also carry through for 4 periods, so basically they are significant longitudinally. So they keep affecting the hospitals around them longitudinally as well. And when we break this down by basic and advanced EMRs, we see that a lot of the short-term effects, first year, second year, are coming from basic EMR applications, and advanced EMR applications only have effects after 4 years. Again, indicating that these advanced EMRs might take more time to assimilate and achieve the impacts. So one additional question we are interested in is the distribution of EMR in the region, the equality. So here we'll look at the Gini coefficient. For example, if there are 2 hospitals in the HSA, let's say, one of them has all 5 EMR systems, and one of them has 0, none of them. This will be a case of perfect inequality in the region. One hospital has everything and the other hospital has nothing. That would be a Gini coefficient of 1. And Gini coefficient of 0 would be a perfect equality. So we look at the interaction between the Gini coefficients and the EMR systems. So this is, again, the spillover level impacts. And we find some significant negative interaction term, meaning that as the Gini coefficient increases, gets closer to 1, the impact of EMR on the other hospitals can increase. So in other words, these results might suggest that not all hospitals have to have the same level of EMR to achieve the maximum spillover in the region. So I'll just quickly, my time is up, so I'll just quickly summarize the results and say public policy implications in 1 minute. So we find some positive externalities of EMR adoption of hospital onto the hospitals that are co-located. And if we translate these results into some numbers, we find that one standard deviation increase in EMR adoption increases hospitals' own cost by 1% and can decrease other hospitals' cost in the area by 2.5% in 4 years. And this for the Healthcare Act for $19 billion, so this could, with the back of the envelope calculations, translates into around $47 billion reduction in healthcare costs in the region. And also, basic EMRs create spillovers faster compared to advanced EMRs, so that should be also something considered by the policymakers. And also, of course, in the long run, it would be the best if all the hospitals have all sorts of advanced EMRs, but since the implementation is really costly, maybe it is an efficient, regionally efficient policy to focus on some hospitals' EMR implementation first and then moving on to the other hospitals, because we have some evidence indicating that regional level optimal outcomes might be achieved without all the hospitals being on the same advancement levels. Thank you very much.
And I enjoyed reading the paper very much. So there are many interesting findings in the paper. The key takeaways, after I read it, is this spillover effect. So hospitals can actually benefit from the EMR investments made by other neighboring hospitals. To me, that's very interesting. And this spillover effect happens mostly due to patient mobility. So when patients transfer from one hospital to the other, they kind of carry the benefits of the EMR investment from the original hospital to the subsequent hospital. I think that's a very interesting, very eye-opening perspective. If we can establish those results as facts, I think there are quite some significant implications. I list two of them here. So at the policy level, governments are making, they have this program that gives financial incentives to hospitals who adopt and accomplish meaningful use of healthcare IT. For those people who kind of believe in free competition or believe in market mechanisms in resource allocation, they will always be skeptical about government subsidies. But based on this paper, if there are indeed spillover effects, there are some social benefits of EMR investment made by one hospital, kind of spilled over to other regional hospitals. It seems more reasonable now the government should make some subsidies to those adopting hospitals. And the competition level, as far as I read, in the health economics literature, there has been a long tradition studying whether hospitals are competing or whether hospitals should be competing. Based on this paper, it seems that hospitals they are more like a competition, so they are collaborating and competition in the same time. They are competing for the same patient base, the same physician base, but in the meantime, they have some positive performance influence on each other. So, the relationships between hospitals, in the same region seems to be more interesting now. So with my key takeaways, I do have a few questions or comments on the paper. I'll start with the empirical one and then move to the conceptual one. So I actually only have one question on the empirical part. That's the research design. So currently, the dependent variable is the average cost of all the neighboring hospitals, which is determined by the EMR investment by the focal hospital. So I start to feel a little bit, I start to doubt the design because by this design, in one region, there are multiple hospitals, so the average cost of all the neighboring hospitals, they are influenced kind of by all the hospitals in this region. So each hospital will create one data point for the study. To me, it's like we are dropping multiple stones in the water in the same time, so the waves are interfering with each other. So I'm not sure if you could just switch the design. The dependent variable is the cost of a focal hospital, and the independent variable is the average EMR investment of all the neighboring hospitals. So so I feel if the results hold to the alternative design, it could be stronger. And especially after I realized the model does not control for the region effects, the fixed effect for the region. Okay, so that's my empirical question. And then, if assuming we can take the empirical results as a fact, I still found interesting about how does the spillover effect happens. I realized two other papers. The first one is in the manufacturing industry. It's all about IT spillover effects of IT investment. So in manufacturing, IT investments made by the supplier industry will have a spillover effect on the downstream industries, because there are direct material and information flows. Well, in banking industry, there are a lot of studies on ATM adoption. So there's a network effect on ATM machines. So, one bank investing in ATM will have a positive spillover effect on other banks. If I use these two studies as a benchmark, I feel I'm not fully convinced by the argument in this paper whether patient traffic is really strong enough to drive the network effect here, or the spillover effect here. We have been discussing the problems of making EMR portable. So given the current status, are the EMRs really portable enough to drive the spillover? Okay, so my last comment, so there might be an alternative explanation. So to me, I don't have evidence, but I feel for large tertiary hospitals, their operating expenses will be higher, much higher than community hospitals. It might not mean community hospitals are much more efficient.
My question's on the first paper. You measured expense at HRR, and I couldn't quite make out from your equation, but some of the HRRs cross over states. So I guess I'm just wondering what the implication of that is. I don't know if the HIEs are state level or specifically region level, but a number of the HRRs cross over state boundaries. So.
Yeah, so generally that's true. What we've looked at is basically, we don't think it has a huge impact on the analysis in the sense that we just focus on which HRR are you fundamentally operational in. So in the sense that, if you have to realize our data in some sense is a little bit older than what's happening in the world today. At that time, we didn't find many HIEs that were operational in a significant way outside of one hospital referral region. They were very much so localized efforts at that time. Today, that may not be the case anymore.
Hi, my name is Niam, and let me be the devil's advocate here in the case of HIEs and tell you why the payers are very skeptical about the benefits of HIE, especially in the hospital settings. The reason is that the HIEs, by definition, are not supposed to have any impact in the hospital settings. Why? Because hospitals, along with the labs and radiology centers, are the producers of data. They create medical records and reports that will be used down the road by other medical providers, especially in the outpatient settings. And the only place that the HIE can help a hospital is in the emergency department. And in the emergency departments, the ratio of access to HIE is about 6 to 7%. It's not more than that. So I highly suspect that the reasons that you see about 1.2% reduction in the costs is coming only from the emergency departments of the hospitals. But there is even a more important problem here, and that is if somebody can defend the claim that mere adoption of EMR can have some effects on the quality outcomes, it would be near to impossible to defend the argument that adoption of HIE will have an immediate effect. And that is because no matter how much a hospital invests in HIE and how much effort it puts in using HIE, as long as there is not enough adoption of HIE by the neighboring hospitals and medical providers in the geographical region that is working, then there wouldn't be any data to use. So adoption of HIE wouldn't have any effect. But I think understanding from the structure of the data that you were describing, there is a solution to address that endogeneity problem, and that is to calculate the adoption rate or penetration rate of HIE within each geographical region that a hospital is located, and see if higher adoption rate of the HIE is happening. It means that there is a higher volume of data available, and thus HIE can potentially have more impact. So I think instead of only looking at whether or not a hospital has joined an operational HIE, you would add a variable and see if a hospital has joined an operational HIE with this specific penetration rate, and investigate the effects of that variable on the quality and the cost of care. It would be much better.
Okay. I think that was directed to me, right? There was a lot of factors in that comment, and I think certainly I would agree that the skepticism around HIE emerges from a lot of different things. One is the incentives we talked about. The other is the lack of penetration in some markets. The interaction between the penetration levels and the effectiveness of the HIE is an interesting, and we also heard that comment before. partially we have some data on that, so we could try to do that. I think what we're seeing, though, is that, given that there is variation in the level of penetration across markets, there's still some average effect that's emerging from kind of this binary measure. As a sanity check, it would be nice to see that that there is this positive interaction between how HIEs create value and the extent to which there's heavy penetration in the market.